Let us learn about robot-assisted sacroiliac screws, which are used in lumbosacral fixation. These are commonly known as S2 alar iliac screws because of their entry point and are a standard practice in long fusions in the lumbar spine. The placement of S2AI screws involves minor modifications in the workflow compared to thoracolumbar pedicle screw placement with robot assistance. Broadly, the steps are the usual scan and plan workflow, with the field of view set to 40 centimeters on the O-arm, followed by planning of screws in the ilium, verification of the trajectory using navigated instruments and planning software, positioning the robotic arm to the specified trajectory, and finally, insertion of the S2AI screws. Schanz pin is inserted into the ilium, ensuring it does not interfere with the planned S2AI screws. It is checked for a sturdy hold, and the robot is physically mounted onto the patient using this Schanz pin with the help of a bridge. Region of interest is then covered with a non-reflective sheet. A 3-defined scan is performed to identify possible obstacles in the path of the robotic arm. While the 3-defined scan is going on, the scrub nurse verifies the instruments by placing them over the reference frame divot. A snapshot of the robotic arm is then taken to register the navigation frame position relative to the arm. Region of interest is marked using a blunt passive planar probe, and the robotic arm is sent to the marked position. A star marker is attached to the robot's arm and positioned as close to the patient's body as possible to cover more segments. The O-arm is then brought in to perform an intraoperative CT. O-arm is brought in with the patient fully covered by a disposable plastic drape. All 4 beads of the star marker must be clearly visualized on the 3D scan. This can be ensured by taking orthogonal X-rays of the surgical area before the final spin. The key to covering a larger area is positioning the star marker close to the skin. During the O-arm scan, a 20-centimeter field of view, or FOV, is standard and is typically used for placing cervical and thoracolumbar pedicle screws. A 40-centimeter FOV is used for S2AI insertion and iliosacral screw placement. It is crucial to ensure that both iliac wings are fully visible when acquiring a 40-centimeter FOV scan. After the O-arm scan, planning begins by marking the region of interest, roughly outlining the spinal canal in the area. The robot then provides probable segmentation, which is verified and labeled with reference to the sacral vertebrae. Once segmentation is complete, planning for the iliac screws starts. The screws are initially oriented roughly along the ilium in the sagittal, coronal, and axial planes. Adjustments are made while scrolling through the CT cuts, ensuring the screw trajectory avoids any breach in the bony cortices. Specific attention is given to the sciatic notch, iliac tables, and acetabulum. After planning the screws, the incision is checked using the software's skin level feature, aiming to place both S2AI screws through a single midline incision. Once planning is finalized, the process proceeds to screw insertion. After planning the screws, the incision is checked using the software's skin-level feature, aiming to place both S2AI screws through a single midline incision. Once planning is finalized, the process proceeds to screw insertion. A common error at this stage is setting the region of interest too narrow on the robot console. If this happens, even if a wider image is acquired, the robot will only display the cropped image. During the planning phase, attention must be paid to the axial, coronal, and sagittal sections. In the coronal view, the screw should start at the midpoint between the S1 and S2 foramina, lateral to the foraminal border. The screw should be planned with 40 to 50 degrees of lateral angulation and 20 to 30 degrees of caudal angulation, with a minimum length of 80 millimeters. The angle of entry at the iliac surface of the SI joint influences the risk of skiving, with more obtuse angles posing a greater risk. This clip shows the insertion of the left iliac screw. For percutaneous S2AI screw insertion, the skin is first incised after positioning the robotic arm to the planned trajectory. A sleeve with a trocar is then placed, and once it sits on the bone, a pilot hole is created using a high-speed drill. Since the pilot hole may not cross the SI joint, a 4 mm tap is passed to extend it beyond the joint. This is followed by tapping with a 6.5 mm tap. And finally, the iliac screw is inserted to the desired depth under navigation guidance. The same steps are followed for inserting the right side screw. This workflow allows surgeons to place S2AI screws percutaneously, minimizing the need for extensive exposure and blood loss. Additionally, it eliminates extra radiation exposure to surgeons, staff, and patients, unlike fluoroscopy-guided sacroiliac screws. The non-availability of a longer 3 mm high-speed drill bit is a challenge that needs to be addressed. Our workflow was designed using the available instruments. The 4.0 mm all-tip tap is sharp, which helps prevent skiving and allows it to cross the SI joint with a lower risk of maltracking. In most cases, the planning closely matches the execution. Let's reiterate the steps for S2AI screw insertion. Drill a pilot hole using a 3.0 mm drill bit through the sleeve and arm guide. Tap with the 4.0 mm all-tip tap, a critical step for maintaining the trajectory, to a depth of 60 millimeters. Tap with the 6.5 mm tap to ensure the entire length of the trajectory is prepared. Insert the 8.5 mm S2AI screw using power tools to minimize maltracking. Verify the final position using fluoroscopy. One of our patients' post-operative CT is shown here, demonstrating perfect placement of S2AI screws with no breaches. Post-operative 3D CT shows proper placement of implants. The robot also facilitates the planning and placement of S1 alar iliac screws, which can be used alongside S2 alar iliac screws for enhanced spinopelvic stabilization. The double screws may help in achieving greater spinopelvic stability. Thank you for watching. If you found this video helpful, please like, share, and subscribe to our channel. Don't forget to check out our other educational content for more valuable insights. Stay tuned for upcoming videos.